Hello, everyone. I'm honored today because I'm standing among respectful professors and colleagues and being part of such a great conference, MOCAT 2026. At the beginning, I don't have any financial interest regarding the products present in my lecture, and I will go fast through the slides because the short time I have. Starting from the definition of keratoconus, as we know, keratoconus is a bilateral asymmetric non-inflammatory disorder that causes thinning and protrusion of cornea, leading to decreased visual acuity and irregular astigmatism. It's important to classify keratoconus according to the severity, and one of the popular classification is the standard Amsler-Chroma classification that depend on clinical parameters such as refractive error, keratometry reading, whether there is cornea scar or not, and the apical corneal thickness. This classification is crucial and important for guiding us for appropriate management of keratoconus. In general, cataracts present earlier in keratoconic patients than normal people, and the most common type is nuclear sclerosis cataract. But we can see other type of cataract, like posterior subcapsular cataract in young patients due to chronic use of steroid for ocular allergy associated with keratoconus. When we face patient with cataract and keratoconus, that means we face challenges. Can simply divide it into preoperative, intraoperative, and postoperative challenges. Regarding the preoperative, we have three issues: corneal stability, appropriate formula of biometry, and what type of IOL to be implanted. So, stable non-progressive cornea are ideal candidate for cataract surgery that mostly done in old age. However, it's important to know that less than 10% of keratoconus progress even after the age of 30. For unstable cornea, we are armed with effective methods to enhance corneal stability like cross-linking and intracorneal ring segment. We recommend to wait at least 6 months after this procedure to do IOL biometry to ensure corneal stability and to get more accurate results. Patients with advanced keratoconus may benefit from combined cataract and corneal tissue surgery as a triple or sequential procedure. Now, let's go to the second challenge of the IOL biometry calculation. Many factors affect accuracy of IOL power in patients with keratoconus, including irregular tear film, difficulty in fixation, and limited zone analysis of simulated keratometry that might missing the big picture of overall corneal curvature. The difference in steepening between central cone and periphery cause K value to be overestimated. Another point related to the apex of the keratoconic cornea is off-centered, making measures depend on visual axis less reliable. Also, there is alteration in corneal ratio between front and back curvature, and don't forget, axial length is equally important, and keratoconic eye tend to be steeper with posterior segment elongation. All these factors can affect the accuracy of the measurement of IOL power. For patients wearing contact lens, it's important to have what is called contact lens holiday, and the time of holiday differs according to the type of contact lens. Now, let's discuss the appropriate formula, or which formula we can use in patients with keratoconus. Actually, there is no ideal formula. There is tendency toward post-operative hyperopic shift. Pentacam more accurate than optical biometry for K value, especially when it's less than 55. Newer machines such as IOLmaster 700 or machines that depend on elevation-based like Pentacam Galili can estimate the total corneal power, help us to complete the picture, and increase measurement accuracy. As we said, there is no ideal formula. Many studies and research is done to find specific formula for keratoconus, but still there is no 100% formula with 100% accuracy. Barrett True K and Kane keratoconus give high percentage of predictive accuracy, especially for ±1 diopter with low mean absolute error. But other formula like HLRBF, EVO, Kane, Barrett, and SRKT formula give good percentage of predictive accuracy, but I recommend to target post-operative myopia according to the stage of keratoconus. And when we have K reading above 55, it's better to use standard K rather than actual K. With myopic target about 1.5 and 2 diopter. So we consider that Barrett through K with predicted posterior corneal astigmatism or measured posterior corneal astigmatism as a preferred option for IOL power calculation, followed by Kane keratoconus formula. SRKT used widely with good results due to its tendency toward myopic error at higher corneal power that counterbalance the hyperopic tendency seen in keratoconic patients. What about IOL? Normal cornea has positive spherical abrasion, while keratoconic cornea has negative spherical abrasion. That's similar to the after hyperopic LASIK. So it's better to implant monofocal IOL with positive or neutral spherical abrasion. These types of lenses we can implant in patients with keratoconus, and again, I don't have any financial interest regarding these products. While these types are not recommended to be implanted in patients with keratoconus. A special type of IOL called IC8, small aperture IOL, has no FDA approval for this indication, but it mitigates the peripheral distortion and improve vision in eyes with irregular cornea. Can we implant toric IOL? Yes, but with some conditions, like patient with mild to moderate keratoconus, and has a stable refraction for 1 year with central regular astigmatism and good visual acuity with spectacles. Toric IOL not recommended in advanced progressive disease, patient wearing RGP or planning for future keratoplasty. Multifocal generally not recommended. During surgery, the main challenge is visualization through irregular cornea. We can solve this with adding OVD or using contact lens. It's preferred to do limbal incision rather than corneal incision, away from the thinning area, and suture it at the end of surgery. To prevent IOL rotation when we're using toric IOL, either implant CTR or doing reverse optic capture. After doing surgery, the story not finished yet. There is possibility of residual refractive error can managed with surgical or non-surgical method, and corneal ectasia that managed by different method like cross-linking, ACRS, or tissue replacement. This diagram summarizes surgical planning of cataract in patient with keratoconus. In summary, patient with keratoconus develop cataract slightly higher than general population. Corneal stability is important. Biometry is challenging in such case, and always target myopic postoperative myopia and use neutral or positive lens. Advanced keratoconus with K value above 55, it's better to use standard K, which is 43.25, with myopic target about 1.5 to 2 diopter. There is no ideal IOL formula, although the keratoconus specific formula, such as Barrett through K, can keratoconus improve outcomes over standard formula. Patients should be informed about the possibility of post-operative glasses or contact lens used to optimize visual outcome. This is my references, and thank you.
Great, thanks, Dr. Sarmed.
Thank you.